The skin is one of the most important organs of the body. It protects and sort of holds and nourishes, in a way, all the other organs. It's a mechanism where we can control our temperature. It's a way to eliminate toxins. You have the epidermis, which is the top layer of the skin. Then you have the dermis, which contains the blood vessels, the nerves. And it also has a lot of the hair follicles, the oil glands, the sweat glands that are also very important to the skin as an organ. Below, you have the subcutaneous or fat level. And everywhere on the body, the dermis and the fat level can vary depending on which part of the body. For instance, our eyelid skin, the dermis is very thin. For non-melanoma skin cancer, the most common way that it will present, a patient will say that I had a sore that was bleeding, or something that scabs, doesn't heal, bleeds again. Sometimes it may be a lesion that they've had on their body that they notice is growing as well. And with squamous cell carcinomas, those can sometimes actually be painful. Most skin cancers, whether it's melanoma or non-melanoma, are usually asymptomatic. I think that's important for a lot of people to know, that you don't wait for symptoms to arise. The risk factors for non-melanoma skin cancer are fair skin and fair eye color. You're talking about people that have blue eyes, green eyes, hazel eyes, gray eyes, etc. Fair skin, fair hair color, so blonde, redheads in particular. Those are sort of the intrinsic factors, the things about you that you can't control. And then you look at other factors that are outside. So living in a sunny climate, spending a lot of time outdoors, number of sunburns you might have. Sometimes an occupation might lead you to spend a lot of time outside as well. So there are outside factors as well that affect the risk of skin cancer. The two most common types are basal cell carcinoma and squamous cell carcinoma. One of the beautiful things about being a dermatologist is, even in this day and age with all the technology that we have, a lot of the diagnosis we make is just by a visual look, and that can be a very quick look. We often will, of course, do biopsies to confirm what a lesion is, and look at it under the microscope when we talk about a biopsy, but many times we, as dermatologists, we can look at a lesion and have a pretty good sense of whether this is a concerning lesion, whether this might be a skin cancer, or whether this is a benign lesion or a benign mole. As a Mohs surgeon, the typical patient that's referred to me is someone who's had a diagnosis of a skin cancer. So most often they've had a biopsy already, and they've been told that they have some type of, most commonly, non-melanoma skin cancer. So at a consultation visit with me, what I like to do obviously is meet the patient, give them an understanding of what their diagnosis is. I think a lot of times as physicians, we rattle off terminology and these words that we use, which are really a different language. So I will explain to them what that diagnosis is and what this diagnosis really means in their overall health. I can tell them this is a lesion that most likely occurred from sun exposure. I will talk to them about whether we're concerned, and if there's concern about, could this lesion come back? So we talk about the different treatment options that are available. What are the risks and benefits of this surgery? What is going to be the recovery time for me? What am I going to look like when I've had the surgery? And what am I going to look like 3 months from now and a year from now? And then also, what now? I have a very good chance of cure, but what do I do now to protect myself, and how do I make sure I'm undergoing the proper surveillance? So the patient will come into the dermatologist, who will then assess that lesion and be able to say, you know what, I'm very confident this is a benign lesion, it's a benign mole or a benign growth, no need to worry about this, or, you know, I'm a little concerned this might be a skin cancer, let's go ahead and perform a biopsy. And a biopsy is a pretty scary word for everybody because it sounds like something invasive. But again, the beauty of dermatology and the skin is that things are very accessible to us. And so for us, a biopsy could be something as simple as what we call a shave biopsy, a punch biopsy, or excisional biopsy, and it's all done right there in the office under local anesthesia and very sort of easily managed by the patient. It's not as scary as it sounds. biopsies of skin lesions are pretty low risk. With any procedure, there's always a risk of bleeding, there's a risk of bruising, there's a risk of scarring, there's a risk of infection, but thankfully with biopsies, it's incredibly rare to have any of those. In the vast majority of non-melanoma skin cancers, usually a biopsy is all that you need to do to work up a patient. The biopsy provides the information of the type of cancer it is, how mature or how immature the cancer is, how deep the cancer might go. In certain cases, I would say probably maybe a little bit more commonly with squamous cell, but still relatively rare, there is the concern that could this lesion have spread or could it be involving deeper structures? And at that point, we may do some imaging as well. And that could be something like a CT scan, for instance, to see if there's any risk or any chance that the tumor has invaded into the bone. If we are concerned that there might be nerve involvement with the tumor, we might order an MRI or to look at nerve involvement or even soft tissue spread. What I can say about skin cancer is that the vast majority of patients I see, they have a cancer, and unlike many other cancers, I can look them in the eye and tell them this is cured, you will not need to worry about this, and now we're going to work on prevention for other skin cancers.